Can you hear me okay?
Oh, that's good.
Hi, Dr.
Dr.
Lee.
Pa. Hi, Dr. Pa.
Nice to see you.
Uh,
I'm glad it's working. The link is working now. I apologize for the confusion.
oh, oh, that's fine. Oh, so can we start now?
Yeah, I'm ready whenever everyone else is.
Okay, I'm starting. Okay, I'm starting to introduce today's speaker, Dr. Judy Pa. And Dr. Judy Pa is currently the co-director of the ADCS, Alzheimer's Disease Cooperative Study, and professor of neurosciences at UCSD. Okay, and she completed a postdoctoral fellowship in Alzheimer's disease at UC San Francisco, and then served 5 years as a faculty member there. And after that, she joined USC ADRC in 2014 and recently moved to UC San Diego for about 1 year. About 1 year. And Dr. Pa has 20 years of a human neuroimaging experience and directs a research lab focused on Alzheimer's prevention and risk factors. And her research is focused on identifying individuals at risk for Alzheimer's disease, understanding how Alzheimer's pathology impacts brain function in the living brain, and developing new multi-domain combination interventions using technology, such as virtual reality and remote activity monitoring, with the goal of preserving brain health and cognition. I think in today's talk, Dr. Pa will discuss some modifiable lifestyle factors, such as exercise and cognitive stimulation for the prevention or enhancement of brain health using neuroimaging techniques. And let's welcome Professor Judy Pa.
Thank you, Dr. Lee. Thank you for that very nice introduction. It's so wonderful to be here. I think you right around noon in Taipei right now. So I hope everybody is getting to eat their lunch. So let me share my slides here. Let's get Keynote going. Let me make sure it's working. Okay, can you see that's my screen okay?
Yes, okay.
Is that working? Okay, good. Just move this over. Okay, great. Shall I go ahead and start?
That's fine.
Okay. So thank you so much for the invitation to be here. It's really a pleasure to be able to see Dr. Lee again and to see or connect with colleagues in Taipei. I've had a chance to visit Taipei and the broader Taiwan a number of times. I used to go back probably once a year for a long time. And so, 不好意思，我的中文不太好. So today I have to give the lecture in English, but I know very, very limited conversational Mandarin. Fortunately, my children, are born and raised in the US, but they have been in a Mandarin dual language program since they were in kindergarten, since they were 5 years old. So their Chinese is much better than mine. So I will speak today on modifiable lifestyle factors for dementia risk. And it really follows this quote of an ounce of prevention is worth a pound of cure. So as we all know, everybody here in this audience is very well versed in Alzheimer's disease and dementia risk. But if we could ultimately, and I think that this message resonates a lot with the perspectives in Taiwan, is that ultimately, if we can prevent the disease, that is much more favorable to trying to treat the disease because we know the disease is so challenging. And as Dr. Lee mentioned, I'm now in San Diego, just looking here at my title, and I'm in UC San Diego, so just traveling farther and farther south in California, and I was able to spend some time with Dr. Lee at USC in LA. And I think Dr. Chu, Helena Chu, is a close friend of everyone's. So just some quick reviews of Alzheimer's disease that is in the news, and I don't know how much of this is discussed in Taiwan. I mean, certainly with COVID, of course, and the pandemic. But in the US, a famous crooner, a famous singer, Tony Bennett, if anybody knows him, he's a famous jazz singer and crooner, recently revealed that he suffers from Alzheimer's disease. So that was really relevant to the age group that we study because everybody grew up listening to his music. This has been very prominent in the news with COVID-19, that they are now recognizing that individuals who have had COVID have Alzheimer's-like brain changes and cognitive dysfunction in some of the individuals, but more than would be expected. And a very recent study just over the last few days found that there's a 69% increased risk of developing Alzheimer's disease in older adults who had COVID and survived. And so another suggestion, and this is correlation data, so take it with a grain of salt, but just that we're finding these associations between having COVID and increased risk for Alzheimer's. And then this, I think, is really relevant to everybody, and folks have been following this in the news, and in the field, but that there's a new FDA-approved treatment for Alzheimer's disease. This is from Biogen. The drug is aducanumab, and generic and brand name Aduhelm. And there's a lot of controversy around this drug. This is the first drug that was approved for Alzheimer's disease in about 30 years. And a lot of work is being done in trying to understand and develop appropriate use criteria, trying to understand side effects, and really who should be taking it, who may or may not benefit. So just to briefly touch upon this, because I think it's so important for our field, is that there's a lot of controversy around Aduhelm and aducanumab, and there's several other companies that now are trying to pursue the same pathway of understanding biological target engagement, despite perhaps no to little evidence of clinical benefit. And so here you can see at the bottom, I have the citation for any folks who are interested, but this is the citation. This is work that was done by a few different individuals in the US predominantly, trying to really understand, what went right with aducanumab and what were some of the problems. And so here I list reasons to deny approval versus reasons to approve. So a lot of the controversy around aducanumab or Aduhelm is that there were violations between clinical trial design and the analysis and what we would expect to be done versus what was done. We're not seeing a lot of correlation in the second bullet here between biomarker change and cognitive change, meaning that the biology that is changing doesn't seem to be mapping onto cognitive benefit. There was also, and this is very striking to me, a 50-50 chance in the sense that one trial was positive and one trial was negative. So the positive trial was emerge and the negative trial was engage. And with all of this, the recommendation from the FDA advisors was that a phase 3 high-dose aducanumab trial is needed to determine efficacy. So in other words, the jury is still out. We don't know if it's effective or not, and certainly don't have evidence of clinical benefit. Therefore, another trial is required. These were some of the reasons to approve, and you may see my bias here, is that the Alzheimer's Association has endorsed aducanumab to the FDA. There was a lot of advocacy work for the approval of aducanumab. There were anecdotal statements that were presented showing with patients who endorsed a positive change such that they self-report notice changes in themselves or perhaps caregivers and their loved ones who are on the drug. And then really this question is some signal better than no signal? There's this notion that there have been so many failed trials for so long that there's enough evidence here to give hope. So ultimately, and I highlight this in yellow, that the FDA did approve on an accelerated basis the Aduhelm or aducanumab based on the reduction in amyloid plaques. And that's the same approval process that is being used by other companies who also have anti-amyloid therapies. So CMS looked into this and is now providing some limited coverage for aducanumab for clinical trials participants only. So now we will see the next phase of trial that comes out from this. And if anybody has questions, please stop me, and I may not be able to see if your hand raised, but you can unmute and ask a question. So in contrast to aducanumab, and for those of you who were at AAIC just this past July in San Diego, is just this one finding that I'll talk about, which is really promising. So this is the EXERT trial. It was a national phase 3 trial on aerobic exercise versus stretching. And the PIs, the principal investigators of this trial, are Laura Baker and Carl Kottman. And the primary paper is not out yet. And so I just, for fun, included this little news snippet from CNN that describes how aerobics isn't the only exercise that could slow mild cognitive decline in this EXERT trial. So the EXERT trial was a 12-month trial looking at supervised aerobic exercise versus stretching and balance types of activities, range of motion, for a total of 12 months. And this was done in partnership with the YMCAs in the country. And the take-home message is that both exercise groups maintained cognition. So despite aerobic exercise or stretching, balance, and range of motion types of exercise, that neither group declined over the 12 months that would have been expected, given that this was an amnestic MCI cohort. So the primary paper will be out in perhaps a few months. And this really just reaches this point in discussion of dementia prevention via lifestyle interventions, such as exercise. So in today's lecture, I'll just touch upon two main points. One of those is lifestyle-based behavioral approaches and clinical trials for primary or secondary prevention of dementia. And then I will finish by describing a technology-based intervention that we are developing in my research lab for dementia prevention using virtual reality, and I have some demos for that. So this is a well-versed audience, but I always like to, when we think about these experiments and projects and the research that we're doing, to think back to the driving biological problem. And so here are some images of amyloid plaques and tau tangles, and this is ultimately the prevention side of it. We want to be able to preserve, this is a brain postmortem of a 75-year-old man who died from non-Alzheimer's causes. And so that we want to keep the brain like this. We want to be able to preserve brain health as opposed to trying to treat it and have growth return, because that's in comparison to this, which is also of a 75-year-old man, but who died of Alzheimer's disease. And so you can see the incredible atrophy in the bilateral hippocampi and the ventricles and overall brain volume. Also, what is fortunate for us to be able to study this disease and be able to intervene early is that we know that we have multiple stages as the disease declines and as the disease progresses and cognitive decline sets in. So we have healthy aging, and then at some point we cross over into mild cognitive impairment, and then ultimately Alzheimer's dementia. And I just highlight that this is the stage that we really focus on a lot for primary and perhaps secondary prevention, but really at this or either cognitively normal or cognitively unimpaired individuals, and then here at the border of those with mild cognitive impairment, but really on the early side of it. So trying to intervene as early as possible, but where there's some indication of risk. Fortunately, just like how the cognitive decline is slow and progresses over time of several years or decades, the brain changes are also slow. So this is just a caricature of mild versus moderate versus severe Alzheimer's disease. And everybody in this audience knows well what that pattern of brain atrophy looks like with bilateral hippocampi, ventricles, overall cortical thinning. You can see as we go into moderate stages that all of the CSF spaces tend to get much bigger and then become very severe. So what is interesting with Alzheimer's disease, but also makes it incredibly difficult to understand and to treat, is that it's very multifactorial. There's multiple factors that influence brain health. So there's a number of factors that we can't change, such as our age, which we know is the biggest risk factor for developing Alzheimer's and dementia, and then also our genetics. But what's nice is that there's all of these other factors here that we can change. So medications potentially that are being taken, physical health, cognitive resilience, and cognitive reserve, environmental factors. And then lifestyle, which we in my lab and many others tend to focus on with lifestyle and different aspects of exercise, diet, and so forth. So the Lancet Commission has come out, and prior to that, Christine Yaffe and Deborah Barnes came out with papers looking really at modifiable lifestyle factors and modifiable risk factors for dementia. And so it originally started out with these 12, but I have this plus. Well, it started out with 9 and it's now grown. But I have this plus sign because there's a number of factors that are not measured, which I'll note here. So things like diet that we think a lot about, sleep quality, and cognitive engagement are not measured because it's more challenging to measure those on a global level. But these were based on worldwide population studies. So this is worldwide, outside of just the US. These factors have been identified as being potential risk factors that are modifiable, such that if we are able to improve on these risk factors, we may reduce the risk of dementia. So education, current smoking, physical inactivity, depression, obesity, hypertension, diabetes, social isolation, air pollution, which was recently added, hearing loss, also added in the second Lancet Commission report, traumatic brain injury, TBI, and also alcohol use. So the development and understanding of this has really progressed even farther than just understanding risk factors, but also trying to understand when these risk factors may have the biggest contributions at what stage in an individual's life. And so here we have green, this is early life, in blue we have midlife, and then in purple here we have late life. And we can see that a lot of these risk factors have been mapped onto different stages of life. My personal bias is that I think there's a lot of crossover. Some of these factors that are in midlife may also be factors in late life. Some of these that are listed in late life may also be factors in midlife, and potentially also the case for education. There is some work here on education being done to suggest that primary education at younger ages may have a different influence than education that happens later as an adult. But we can see we have education down there in early life, and then in midlife we have hearing loss, TBI, hypertension, alcohol, excessive alcohol use, and obesity. And then as we get into later life, smoking, depression, social isolation, physical inactivity, air pollution, and diabetes. So all of these together add up to potentially 40% of risk that's modifiable. And then the other 60% of risk is more unknown. And some of that could be captured and attributed to those other factors that I mentioned that were not measured. So we like to think of lifestyle interventions as medicine and really as a form of behavioral medicine, and really trying to think about it from a prevention perspective. So whether or not we can either keep a brain like this with no plaques, or from a primary prevention perspective before the onset of any clinical symptoms, if an individual who does have evidence of Alzheimer's plaques or amyloid plaques in the brain, whether or not those could be cleared. And that's still very much an open question. But there's more and more studies that are collecting this data in trials to be able to see whether or not there's a change. There's a lot of aspects of that to consider, because the clearance or movement of amyloid plaques, unless it's an anti-amyloid therapy, but in behavioral types of interventions, it may take a while to be able to appreciate any of those changes. So why do we think about lifestyle interventions? And my training is in cognitive neuroscience, and I like to think about mechanisms a lot, specifically within the brain. And there's a lot of evidence documented from animal and human studies to suggest all the positive benefits that happen from lifestyle-based interventions. So things like neurogenesis, so the birth of new brain cells, increased network connectivity in the brain, the diversification of cell structures with different types of exercise and different lifestyle interventions, increases in cerebral blood flow, CBF, measured via ASL perfusion, for example, neural activity and cognitive activity that's also associated with these interventions. And then there's a lot of evidence to suggest that it decreases negative events in the brain. So it decreases insulin resistance, arterial stiffness, cortisol, obesity, and inflammation. And these are long lists of good things that are increased and bad things that are decreased. And so what's really interesting about these types of interventions is that they may have multiple mechanisms that are hitting on multiple targets, and there may be interactions and synergies between them. And that's a lot to tease out depending on what the combination of therapies is, but really something interesting to keep in mind. So there's evidence, and I just show a few results here from different papers of colleagues. And so brain improvements through lifestyle interventions, this is just a snippet from the pivotal paper that came out from Kirk Erickson in 2011 in PNAS, which showed that over a 12-month aerobic exercise program that there was actually increase in volume in the hippocampus. So you can see the bilateral hippocampi here highlighted in yellow. And the blue group is the aerobic exercise group, and the red line here is the control group, which was stretching. And we can see here that individuals in the aerobic exercise group over a year had increases both in left and right hippocampi relative to the stretching group that declined. And this is typically, I mean, we can see on the y-axis what the units are, but typically in an older adult, we would expect 1 to 2% of atrophy in the hippocampus over a year. This is a separate paper that was done here in the bottom left, done by Adam Brickman. And this was a really interesting dietary intervention that was conducted using flavanols or flavonoids. And flavanols, it was a supplement, and so it's hard to get this level of flavanols in just regular food items because it was so high, but this was done in a supplement. But flavanols are found in leafy greens like spinach, dark chocolate, some red wines, and other antioxidant foods. But this via a supplement, and Adam Brickman was able to find that pre and post this intervention of those who are on low flavanol doses versus high flavanol doses found increases in cerebral blood flow in the hippocampus. So here, these are segmented three-dimensional models of the hippocampus overlaid with where different areas increased in blood flow in CBF. And you can see that here as well on this, this coronal slice. But what was interesting is found that there was an increase in CBF in the hippocampus, and then that increase in CBF correlated with clinical benefit. And so the change in CBF mapped onto the change in improvement in memory scores in these individuals. And then this last one here on the bottom right is a paper that we published with Deborah Barnes. This is her MAX trial. This was in 2014 in JAGS, and found a benefit in a stretching, low intensity cognitive activity and physical activity group combined actually had benefits in sleep. This is self-reported sleep using an NHANES survey, but found that those activities that were a bit more restorative improved sleep quality in these individuals. So much so that one of the sub-questions on this questionnaire found that they were less likely, or it reduced how the amount of sleep aids that were taken, of medications, sleep medications, which is really was remarkable. It left an impression on us because we recognize how difficult it is to get individuals to stop taking sleep medications. So there's many unanswered questions in the field. One of them, and this is really important to our work, is really trying to understand with, potentially 12 to 15 modifiable lifestyle factors, it's nearly impossible to ask any person to change 12 to 15 things about their life. So what we would really like to understand is, what is the right intervention and for whom? Or what is the right combination of interventions and for whom? And this gets back to a precision medicine approach of wanting to understand, based on one's risk profile, what sorts of activities would be most beneficial. Because getting an individual to change one or two aspects of their life is already quite challenging, as we know. So here are some open questions. With many possible lifestyle changes, how can we have the greatest impact via combination therapies? Also, what is the benefit to older adults, especially those who are at risk for thinking problems or Alzheimer's disease? And so wanting to understand mechanistically, how does intervention X map onto outcome Y, depending on what the goals are. And then again, mechanistically, how do healthy lifestyles impact brain and cognitive function? So those are all some of our unanswered questions that we're pursuing. I wanted to share in a little bit of detail here the finger trial that was done in Finland. This was, many of you may be familiar with this. This was a 2-year multi-domain intervention of 4 specific interventions. And so getting back to combination approaches and monitoring different types of lifestyle factors and intervening on them, and then potential synergies or interactions between them. So in this study, they looked at diet. In the finger study, they looked at diet, exercise, cognitive training, and vascular risk monitoring versus a control group. And this was done in Finland. So this was the first long-term. It was for 24 months. So that's a good duration for lifestyle-based interventions. That was robust and rigorous in its design and had a multi-domain intervention and a large final sample of 1,260. Just sharing the consort diagram, I think this is always very helpful to look at to understand the full scope of the project and all of the effort and work that goes into it. So they started out with over 2,600 individuals who were assessed for eligibility. Of that, a little less than half were randomized. That's not bad. And these are all the reasons why they did not meet the enrollment criteria. Of that 1,260, about 630 in each group, either intervention and control, and then based on completed assessments and different reasons for discontinuation, in their modified ITT analysis, they ended up with a total of 591 in the intervention group and 599 in the control group. Here are their outcomes. This was a positive trial. Their primary outcome measure was cognition using the NTB. And that stands for Neuropsychological Test Battery. It's well documented in the literature. And you can see on the NTB total score, we have the intervention group in red and the control group in blue. And we can see some separation there that is significant. In the executive function group, we also see a separation that is meaningful between the two groups. And interestingly, with it being an executive function, because there is some evidence to suggest that individuals who participate in an exercise trial, and this also had vascular component to it as well, may have differential benefits to different cognitive domains, such as executive function. Processing speed also was significant, and what wasn't different was memory. So it would suggest that within this NTB total score, that these differences may be more tied to changes or improvements in executive function and processing speed and less so in memory. Just for reference, the intervention arm increased by 0.2 points over 2 years relative to what we would anticipate in individuals with early AD to decline 0.2 points over 2 years. So this shows that not only did they get better, not only did they not decline or stabilize, the participants actually got better on the group level. So the fingers trial in Finland drew a lot of attention, and there became a lot of interest in multi-domain interventions. And so this birthed the project of Worldwide Fingers. And it's a global effort towards addressing and reducing combination risk factors across cultures and continents. So you can see there's a lot of individuals involved on a global level. And here is just a table to show some of the groups, and I just highlighted this for US Pointer because Worldwide Fingers within the US is called US Pointer. It's well underway. They are really on track with their recruitment numbers. They targeted, they had a target enrollment of 2,000 individuals, and they are well on their way of getting those 2,000 individuals, and also from a very diverse racial and ethnic breakdown. And so that was one of the goals of US Pointer, was to also have a representative sample. And then just to show it to you on a map level to understand worldwide fingers and the anticipated reach globally is all of the countries here, the ones in blue, and this is Alaska and the US, and the ones in blue here and in Europe and in Asia and Australia are active, and then the other ones are the lighter blue are in the planning stages. This paper came out about a year ago, so it's also changed, and they are still recruiting sites. So they have an ambitious and critical effort being put towards design and, importantly, data harmonization. Because if the data are harmonized and the outcome measures, as much as they can be, are harmonized, and despite being in different languages, that then would enable an ability to examine it, on a global level. So now I want to just shift gears a little bit with priming you with US pointer and worldwide fingers to talk about combination therapies, and something that we're working on in our lab and research and have completed some early pilot studies using technology. So technology-based interventions for dementia prevention using virtual reality. So this project here is called Rescue Ranger VR. These are our local efforts at UCSD. It is a 16-week, 3 times a week, moderate to high intensity cycling, as opposed to walking or running. They're on a stationary bike. And the target is individuals 50 to 80 years of age and 150 individuals. And this is an NIH-funded study. The rationale here for this is really this marriage between health, neuroscience, and technology. So wanting to use a combination treatment of concurrent exercise and spatial navigation in a virtual reality environment. And this builds upon foundational neuroscientific principles of neurogenesis, long-term potentiation, and dendritic spine density, with this notion that neurons form new memories from the exercise proliferation and integrate into neural networks in an enriched environment, because there's cognitive stimulation, meaning that there's a cognitive task involved. So whenever we embark on these new novel types of interventions, we always like to think about what our hypothesized target pathway is. And so taking us from our intervention here of combined physical and cognitive activity, this person's riding a bike, it's a stationary bike. So we don't actually put them on a bike and set them free in the world with VR, but they're in the lab on a stationary bike. So with this combination of physical and cognitive activity, we like to think about what our gold standard is, which is essentially cognition. And all of the different brain activities and events that could take place to get us there. So we think about physical and cognitive activity, increasing neurotrophic factors like BDNF, VEGF, and IGF-1. These increases in neurotrophic factors can map onto other neural events that happen, such as neurogenesis, long-term potentiation, synaptic plasticity, dendritic spines, and cerebral blood flow. That can happen here in the hippocampus, and the hippocampus we know has a lot of connectivity to the prefrontal cortex. And with these types of activities, we think that they may benefit executive function and memory. And so that can enhance network connectivity and ultimately get us to our gold standard of wanting to enhance cognition, importantly, memory and executive function. So I'm going to show you a little bit about this intervention. This was all created in the lab with a team of interdisciplinary individuals, engineering students, staff, neuroscientists, neurologists, everybody who would be interested in something in an intervention like this was welcome to participate. So here, I'll read you the narrative. Rookie Ranger, the animals have escaped. With the help of Buddy the dog, your mission is to find and return the animals of Sal's sanctuary. As you complete your mission, you will move up the ranks and earn new badges. Let's go. So this is a picture of one of our older adult participants with the VR mask on, VR headset, on our stationary bike that we built. In the back here, you can see what the participant is seeing through the VR headset. And then, so he's looking at this road. And then if he was to look to the right, he would see this pasture here with these deer that are grazing. And then if he was to look down, there's this little picture-in-picture just to show you what it looks like if the participant looked down. That's Buddy the dog there sitting in a basket. And then this is a gauge that shows the participant what their heart rate is. So they are wearing a chest heart rate monitor. And then that heart rate monitor feeds into our software to then display it in our code to then display what their heart rate is here on the monitor. And here's an example of what it looks like. You'll see me biking, a picture of me will show up, and you'll see me biking through the environment. This is a bird aviary, so it's fully enclosed, and there's birds that fly around. There's encoding trials and retrieval trials similar to a Morse water maze design. And so these arrows that are here on the ground indicate to the participant where to go in the path because there's certain decision points. You can go straight, I can go left, or I can go right. And so this is an encoding trial where I am being taught the path. So here we go. So I'm moving through it. You can see that I'm biking, and the handlebars, if I turn them left and right, indicate which direction I'm going. So there's that red arrow that pops up. It shows me to turn, it indicates to turn to the right. There's also these bubbles on the side that contain objects for me to collect to help take care of the animals. And then as I get to the very end of the environment, I get to fulfill my task, which is to feed the animals, and I depress the handlebar brake, and that shoots the food out to the animals. And then you can see these little hearts here, the little emoji hearts here that indicate to me that the animals are happy. Just to keep things very real, we were in the middle of conducting this during COVID. When the pandemic hit and we fully shut down for 6 months, and it was very challenging, as it was for the rest of the world. But once we were able to get back into the lab and to bring our participants back, those who felt comfortable coming in, we had to really think about how to make it safe and how to protect our participants, especially because they're older adults and they may have different compromised health systems. And so here, we have our older adults sitting here on the bike. We fortunately were in a space that had an outside door, so we were able to open it and hung a screen there to protect from bugs coming in. We have a HEPA filter here. We had a different system that used a UV light to clean the headsets after every participant. You can see the participant is masked, and we have a fan. So we took many, many precautions, and I'll say that after we were allowed to re-engage with participants and reactivate our research, we successfully collected over 200 visits in the lab, and nobody got sick. So participants remained COVID-free from exposure in the lab, and so did the research staff. And so we were able to properly mitigate risk here with the setup, but not without a lot of care and diligence towards cleanliness. Here are just a few reasons why we were very interested in using VR, as we know that behavioral modifications are very difficult to come by. We wanted to think a lot about adherence and mechanisms of adherence. And so within our virtual reality environment, we were able to include several factors that enhance participation and enjoyment of the game. So we have gameplay, which they really enjoy and find pleasurable, going through the environment and seeing the animals. This also changes our eligibility because many folks who want to do exercise-based interventions are already exercising, but they may not have much room to move. With this type of intervention, because we are adding on the cognitive piece to it, we have the ability to recruit a bigger and more diverse group of participants. There's a bit of social connectedness. There's competition and leaderboards, and that also is a motivator for participants. And then we have game design. So for example, after they bike 500 miles, which they did in our virtual environment, after they bike 500 miles, they get a badge, and it gets placed on their virtual office, their their home base that they get to return to after every session, and they get to see all of their accolades and their awards, which they really enjoyed. Just another aspect of technology that we've included is accelerometers. And we, outside of the VR trial and in a previous study, we were able to record accelerometer data for 30 days continuously. And this is just an example of some of that data that comes off of this gene-active device. This gene-active device comes out of the UK. It allows us to capture day-to-day variability in both activity and sleep. And so here we have measurements, total, this is a measurement of mg, which is gravitational units of movement, over multiple days. You can see that here, down here shows days of the week. Also a sleep period, how much they slept on those different days, and then their sleep efficiency. What was the quality of their sleep like? Even if an individual spent 8 hours in bed, was only 6 hours of the 8 hours actually of higher sleep quality. And then just to give you a sense is that this is truly big data because data are sampled at 100 hertz. And so you can see all of the movement while this data being collected, and then there's a lot to consider with the best way to analyze this type of data. But we can see this movement, and then there's different shadings that demonstrate what types of activities they were doing, if it was more light physical activity, moderate, or vigorous, and then times when the device was taken off. They were asked to leave it on at all times. The battery can last for 30 days, but there are times that they would take it off if they went swimming or were doing other types of activities. We also really like to think about brain mechanisms, and so we are engaged in collecting high-resolution hippocampal volumes. So this is just from a 3T analyzed using ASHA software. And you can see it's a really nice image here of the hippocampus wrapping around to entorhinal cortex and so forth. And using the ASHA software, we can start to look at hippocampal subfields. And here's an example here of that. So we have the dentate gyrus, where in the of the subfield of the hippocampus, which we hone in on for neurogenesis. Then we can see CA1 and then wrapping around and continuing down to entorhinal cortex. This is a pilot study that we completed. This is published work with just 12 individuals wanting to look at effect sizes. And so we looked at cognitive flexibility, inhibitory control using the flanker, and pattern separation, which is a memory task. And we wanted to study this over 4 time points, even though the intervention was a total of 12 weeks. We wanted to examine multiple measurements of change in cognition, because we know oftentimes that if we rely just on baseline and follow-up, which is 2 time points, if there's something off about that follow-up, we may not be able to capture change as well that way. So this gives us really a trend of change. So we have 4 time points here, and you can see a trend upwards and then a trend downwards, because that's on the y-axis is reaction time. So this is time versus accuracy. We also looked at brain outcomes in our 12 individuals, again, just a pilot study, and we found overall that brain size increased over time. So we had some limited increases in total brain volume, and this was really with a grain of salt because the intervention was only 12 weeks, and we recognize that being able to identify structural brain volume changes may really require a much longer duration. But we picked a few ROIs that we thought would be meaningful. So it's total brain volume of gray matter, middle frontal gyrus, and superior parietal lobule. So in our models, we also like to think about our intervention to our outcome, thinking about mediators that may influence that. And that could be brain volume or structure or function, brain pathology, and also adherence. How much of the intervention did a participant actually do? Within that, and this is getting back to our goal of precision medicine, wanting to understand what other factors may impact mediators or impact these relationships overall, things like age, sex, gender, APOE4 status, and education. So these are all planned models, and we look at this a lot too with just cross-sectional big data. And this is just an example that I'll end on with our overall goal is to reach a personalized approach. So I'm showing a case study here. So this is for a given individual participant in one of our studies, had several protective factors, 18 years of education, was not retired, was still actively working, had a high demand job, so a lot of cognitive demand there, no depression, and was a non-smoker. But also had several risk factors. 66 years of age, that's still relatively young, but we know, at least in the older age range. With female, subjective MCI. So despite having a high demand job and not being retired yet, she was still endorsing subjective MCI. She felt like her cognition was worse than it was a year ago, worse than it was 5 years ago, and maybe or maybe not worse than her peers. Sedentary, was physically inactive but hoping to get back into it. Had meaningful hypertension, BMI of 27, and was an APOE4 carrier. So if we were to think about this targeted treatment for an N of 1, which risk factors maybe we want to target based on the evidence? So certainly the sedentary behavior, wanting to have the person engage in more physically active activities that she enjoys so that there's maintenance of those activities. Also treating the hypertension. I mean, I think we see again and again that untreated hypertension is very bad for, not just the heart, but for the brain. And also with the subjective MCI, perhaps there are more demanding or other types of cognitively stimulating activities that she could participate in. So this is just an example of perhaps 3 areas that we might try to impact. So can we think about developing targeted concurrent treatments that can improve multiple risk factors and reduce burden? And that's really where the idea came of trying to get creative and how we target these different risk factors. So just looking forward, some areas that we're really keen on is wanting to think about physical activity, cognitive activity, and hypertension and vascular health as some key areas to impact for modifiable lifestyle factors. And this is aligned with a recent National Academy of Science, NIH, and Alzheimer's Prevention Steering Committee that I was a part of that helped identify some of the key factors are those that have the most empirical evidence. With current times, having a focus on remote data collection and home-based interventions, really wanting to be able to put things more in the home based on the current state of the world. Also engaging a more diverse population. We have one study that is promising that we're working on in which we may be able to engage a Spanish-speaking community in a cognitive training type of intervention, and also engaging more diversity from a racial, ethnic, and urban rural perspective. So we really feel that we have a prime opportunity now and a lot of momentum to target and guide combined behavioral and potentially pharmacological and perhaps a combined behavioral and pharmacological intervention to promote brain health. And with that, I want to thank everybody in my lab. This was us at AAIC this year in San Diego, those who were able to make it, and a fun picture, and really several people in the lab that have boots on the ground and do all of the work daily that I'm really fortunate to be able to work with. Our funding coming from NIA and of course our research participants. With that, I'll say thank you to all of you for listening, and I have my email address here in case anybody would like to reach out. We always have an open door policy on collaborations and visiting scholars and potential postdoc positions. So really happy to be here today and to be able to answer any questions you have.
Okay, and thanks for Dr. Pa's wonderful talk. I think the prevention is maybe much important right now because the medication is not significantly effective. So is there any question from the audience? Okay. There's a question from Professor Hu, and he is asking regarding the VR trial. Does it need a placebo group?
Yes, thank you for that. So in the VR trial, we have 3 arms. So one arm is the arm that I showed you, which is the cognitive training and exercise arm, and that's a combination in VR. So what we've also done, because it's a combination approach, is to also pull out each arm separately. So we have an exercise arm only, in which individuals will come in and bike the same amount of biking, but just on a regular stationary bike, just the type that you would see in a regular gym. In addition to that, we have another control arm, which is the cognitive training arm only. So individuals sit on a bike that we've made, and they put on the VR headset, and then they move around the environment, but they're not actually cycling. It's a gas pedal that they push down on, and then that makes them go forward. So that's how we remove the exercise component from it. So it's either combined with the experimental intervention arm, or it's each of the arms separately, just exercise only or just cognitive training only. And those are our 2 control arms.
Yeah. And okay, and Dr. Pa, I'm asking you a question about how early do you think that we need to start the lifestyle intervention? Maybe someone think that age is the most important factor, but someone maybe think that the subjective cognitive complaint is the most important factor. And what's your opinion?
Yeah, it's a great question, and we think about that so often with at what point do we intervene? With these types of interventions, the mechanisms, I think, are so varied and beneficial that it's never too early to start, and it's never too late. So if an individual is of an older age but really starting to experience some changes, it's still, the evidence suggests that there's still potential benefit there. And what I like to think about on the younger side is that sometimes it can be hard for middle-aged individuals to think about their risk for dementia unless they're starting to experience it in the family, with a parent. But I like to think of it as, a savings account, that whatever we're doing now to protect our brains is going into a savings account to be able to help protect our brains down the road in case pathology begins to develop. And this gets back to the theories around cognitive reserve, that there's individuals that, despite having substantial brain pathology, despite having a head full of amyloid plaques, they are still cognitively normal and will die cognitively normal. We're even seeing this in those that have a meaningful degree of tau pathology now with tau PET. And so there's something, special, but maybe not special about these brains, just in the sense that there's protective factors that are allowing their brains to still function despite the presence of pathology. So never too early and never too late.
Yeah, thank you. Thank you for your answer. Is there any question from the audience? Okay, I'm asking another question. And I think the report of the finger study showed the lifestyle intervention improved the executive function and the processing speed. And is there any evidence for the lifestyle intervention can improve the memory? I think the memory is maybe the first concern of the MCI or early Alzheimer's disease patient. So is there any evidence for that?
Yeah, that's a great question. So the finger study was multi-domain, was looking at a number of, the 4 different areas that I mentioned. There are other exercise studies that have, and not just exercise, but also cognitive training. We hear a lot about cognitive training, POSIT, and, there's questions about, brain HQ, and questions about playing bridge or crossword puzzles and so forth. There have been some empirical studies that have shown improvements in memory with lifestyle-based interventions. Exercise, there's probably more literature around executive function, but there are studies that have shown improvements in memory as well. And so it gets back to this, who are we studying? Who are the individuals? And trying to get to a precision medicine approach of understanding why memory is improved in some individuals, but perhaps not others. And it may depend on how impaired their memory is from the beginning. Because if their memories are, if their memory functions relatively intact, then it's difficult to improve it. It's difficult to push it because it's still, it's still functioning. But it's in individuals who are starting to have some of those changes early that that we might be able to see more movement. So it can depend on which intervention, but there are certainly ones that have shown improvements in memory.
Okay, thank you. And there's another question from Dr. Huang. And his question is, do you design intervention based on culture health, seeking behavior in different populations?
So cultural health, let me read this question. I think I can pull it up here.
So what is cultural health is maybe
Oh, I see.
from,
So based on a given culture, what sorts of behavioral changes they're looking to yeah, so this is such a good question. And actually it's so funny. The last time I was in Taiwan, I was having dinner with Dr. Lee and a number of other individuals, and one of them was talking to me about exercise and saying that to her, culturally, being physically active is just as important as being physically inactive, in the sense of resting and meditation and having a chance to calm the mind, to take us out of being so busy and running around and having very stressful life events, but to also taking a moment to just and I think the best way to describe it is to meditate, to be able to have mindfulness and to calm the mind. And so I feel like this question may be getting at that a bit, is trying to understand different cultures and what types of health practices may be relevant to a specific culture. In our studies, we have focused a lot on exercise and cognitive training. So these are both active as opposed to, I don't want to say passive, but as opposed to being inactive or more calming. But I do agree that there's a component here that we're missing in the way that we're thinking about these designs, because they're not relevant for all cultures. And it has come up again and again in some of our designs with the way that we're designing our intervention. Does that resonate with somebody of a Latino background? Does that resonate from somebody of a Black African American background? And so we've had to think a lot about cultural relevance of the way that we're approaching our science and our recruitment and all aspects of it, because because the folks that we study are very diverse.
Yeah, I think that's true. The participants is very diverse, so different kind of interventions must be selected. But how to select it? Maybe we need more study to answer the question. Okay, another question from Dr. Hu, Professor Hu, and are there side effects of VR intervention? The participants will feel dizzy or something like that.
Yeah, thank you for that question. We had the same question ourselves. We actually conducted a pilot study that's published on this. And so we wanted to see, a natural question that comes up is, we think about virtual reality, we're in this virtual environment, it can feel like a video game. Would an older adult, somebody 65 to 85, like to be in this environment because it may feel foreign if they don't play video games, for example? So that was one of our reasons for wanting to conduct this study and also look at side effects. And so we conducted a study with 20 younger adults, 20 older adults, to be able to compare what is their level of enjoyment. And to get to your question of side effects, what are the side effects with VR, and do they differ in older and younger individuals, thinking that our younger group is really our core group, and then our gold standard of what side effects may be, and then compare that to our older individuals. And we did find about maybe 10 to 15% of individuals did have significant motion sickness, and they could not do the study. So they would go in for it varied. And it was interesting too to see symptomatically how those side effects came about. Some individuals became very dizzy within a few minutes, and some became dizzy over an hour. They were fine in the beginning, and then it kicked in later. So that was very informative for us because we redesigned our study a bit based on that. So the speed at which they could cycle was a little bit slower. You can imagine that if you're in a virtual environment and you suddenly turn left or right and made a complete U-turn, that could be quite dizzying in the visual display. And so based on that feedback, we were able to make some modifications to the design. But we do anticipate with our larger trial of 150 individuals that when we're screening, because we do, once they make it past the initial screen, they come in and they screen in VR to see if they can do it. We do anticipate 10 to 15% of individuals not being able to do it based on that pilot study. But that's the predominant side effect.
Yeah. So the side effect maybe persist for several hours. So some participants may feel dizzy or any discomfort for many days or weeks.
Yeah, I would say it was more acute. So if they did feel dizzy once they came out of VR, they felt fine. There was some individuals who didn't get dizzy until later in the session because they were in the session for about, well, the test session was pretty short. That was only about 10 to 15 minutes. And some of them did stay dizzy for later in the day and they went home and took a nap and then they felt better. But it varied. Some it was very acute, and as soon as they were out of VR, they were fine. And then there were others who that dizziness persisted for a little while for that day.
Okay, thank you. And is there any questions from audience? Okay, I think that the time is ended, is limited, and I'm very thank you for Dr. Parr to have this talk, and maybe see you in Taipei in the future.
Yeah, I think there's a conference in Taipei in 2023 or 2024 that I'll be at. So I'll be there at least then.
Okay.
Well, thank you so much for having me, everyone. It was really wonderful to be here and to be able to hear a little bit about your interest in this and to share some of the research that we're doing. It's always really a pleasure.
Yeah. Okay. And thank you.
Okay. Thank you.
Thank you.
Bye.
Okay. Bye-bye.